if you're someone with cardiac dysfunction, if you're a geriatric who has history of heart issues, right? Or let's say you are in the hospital with some sort of disease process that has put your heart at risk, okay? Then what is going to happen? Is that going to be a good thing?
No.
No. How will your patient, if your patient is tachycardic and they're no longer tolerating this tachycardia, what's going to happen? What do you think? What'd you say? Okay, yeah, they could totally code, sure, whatever, yeah, absolutely. What else? What else could happen? So think heart failure, right, guys? So think heart failure. So when your heart starts to fail, when they're no longer tolerating this, what happens to your lungs? They fill up, right? They have some pulmonary edema, right? Essentially what happens is you start showing this heart failure kind of situation, right? You have pulmonary edema, maybe you have that increased cap refill, your kidneys are going to take a hit, your skin is going to take a hit, your liver is going to take a hit, all because you have decreased cardiac output, okay? Does that make sense? Okay, questions about that, about our little review? Okay, so let's talk about stroke volume. So stroke volume is exactly what it says in the name, okay? I do not want you to memorize this, okay? I'm not going to ask you on the test, what is stroke volume, okay? But do I need you to understand the concept? Absolutely, okay? So again, you can read that. The amount of blood ejected from each ventricle with each heartbeat, okay?
From both sides, not just.
Correct, yeah. So again, what stroke, right? That's each beat, volume. So we're talking about volume, right? So fluid, stroke, volume. Okay, and then within stroke volume, there's 3 things that affect that, okay? 3 things that affect it: preload, afterload, and contractility, okay? The drugs that we've learned, the pharmacology that we're going to go over today, all can, not all, but some of them affect this. We can manipulate this to help our stroke volume. Why are we doing that? Well, because we need to make sure that we have a good cardiac output, right? For a normal cardiac output, anybody remember? Okay, you don't have to memorize that, but 4 to 8 liters per minute. Okay, so again, this is what we want. Okay, cardiac index is a little bit more specific to the patient based on their body mass, okay? But cardiac output 4 to 8. This is someone that everything end organ perfusion is occurring. Your skin is perfused, your kidneys are perfused, your liver is perfused, your GI is perfused, okay? Questions about this? Please don't memorize 50 mLs to 100 mLs, okay? I will never ask you that. Okay, so the link between stroke volume and heart rate, we kind of talked about this, right? They're best friends. So stroke volume normally produces a change in the heart rate, okay? So again, for whatever reason, stroke volume falls. Heart rate, being the best friend that it is like, yo, I got you. I'm going to increase to help you out. Because for whatever reason, you are low, okay? Stroke volume, again, from hypovolemia, for example, we've lost that preload, okay? We've lost that preload. Hypovolemia from like what our guy we talked about, GI bleed, okay, is low. So then what happens is the best friend's heart rate is like, I got you, so I'm going to increase. Okay, again, name of the game, maintain that cardiac output. Okay, so we have low stroke volume, okay, we'll just do this. So what happens is the best friend heart rate is like, I got you, bro, okay? And then hopefully we can maintain that cardiac output. Again, depends on the situation. Maybe that person can't maintain that heart rate. So again, looking at our guy, right? Mr. Smith, okay? Mr. Jar, we'll just call him Mr. Jar, okay? Mr. Jar, because he loves the vodka, okay? So he has low stroke volume due to hypovolemia, right? What is driving the hypovolemia? Probably because he's freaking dehydrated, because it's Phoenix and he's not eating or drinking, coupled with the fact that he has a GI bleed, okay? So his stroke volume is low, which tells us that he was tachycardic, right? Didn't I say that his heart rate was in the 110s to 130s?
Yes.
Okay. He's trying to compensate to maintain that cardiac output, right? Okay. But do you think he was very successful? No, you're right. He wasn't. Why? Why was he not very successful? Why was, despite his heart rate being in the 130s, he was not successful at maintaining this? Okay, excellent. Yes. So he was missing the volume. But what about his patient presentation? Think back to the report. What about it concerns you? Yes, absolutely. Excellent. So proud of you guys. So again, cardiac output. Okay, if you're not maintaining, the organs start to drop off the cliff. Okay? Skin-wise, we kind of talked about it. Pale, if you were going to do a cap refill, probably greater than 3, right? He probably was a little bit clammy and diaphoretic. Again, we had that mixed picture with that alcohol withdrawal. However, the key thing here was the fact that he had low urine output. Okay, low urine output. Does that make sense? Okay, good. Okay.
Wouldn't that be evidence that he wasn't successful?
Totes.
Not necessarily the reason he wasn't successful.
I guess I'm trying to distinguish the reason versus evidence. No, I think you're right. It is evidence that the cardiac output was low. The reason is because he's hypovolemic with the GI bleed and dehydrated. Does that make sense? Okay. I had to think about what the definition was of reason and then the definition of evidence. Okay, so here's a really good picture. I apologize that it's like lame and kind of, you know, what is it? Blurry, but you guys, it's gonna be fine. It's in your thing. You can read it, okay? So, of the components of stroke volume, I know this is gonna look. Let me just get black. Black is the name of the game, right? You can't go wrong with black. Okay. So here is. So remember, stroke volume is composed of 3 facets, right? I'm just gonna write it over here because I don't want to crowd you guys. It's claustrophobia. Okay, so remember, volume, right? So stroke volume, we have preload and then afterload. And this is what this picture is depicting, okay? So preload, right, is the volume of the blood in the ventricles, blah, 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 end of blah, 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 end of diastole. I don't want you to memorize that. What I want you to know about preload is the volume, okay? It's the volume. It's the return of the venous blood, okay? What number do we have that we hook up to a central line that can tell us about preload? CVP, excellent. So the central venous pressure helps to tell us about preload, okay? Helps to tell us about preload. That is an objective data point that we have that can paint the picture, okay? So when we have an increase in preload, which we'll talk about, you could have hypervolemia, heart failure, valve issues, okay? Decrease, we'll talk about hypovolemia, blah, 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 okay? Afterload, now again, afterload is the resistance the ventricles have to overcome to pump blood out, okay? Through the pulmonic valve as well as the aorta. So what I think about, how I think about it, right, is when I'm thinking about, so sorry, I said I wasn't gonna cause claustrophobia, but I am. So this is your heart, okay? Albeit a bad one, but whatever. So if you think about a straw, right? It's pretty straight, you guys, wow. Okay, so this is the resistance, this is your vasculature, okay? So your heart has to pump blood through here, okay? This is pretty thin, right? So this could be considered some vasoconstriction, okay? Now, if your heart was like this, and you had vessels like this, okay, a little bit bigger, right? This is tiny, this is bigger. What would be easier to pump out? The bigger, right? Okay, so again, we'll just put normal vasculature. So it depends on the situation, right? But again, afterload is the resistance that the heart has to overcome to pump blood forward, okay? Okay. And we, again, have the drugs that we're gonna go over that, can manipulate this, okay? questions so far? Okay. Okay, so let's bring this concept home. Okay, so preload. We described it as the volume of blood that exerts a force or pressure, blah, 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 on the stretch on the ventricles during diastole. Okay, there's a lot of words there, but what I need you to understand is that it's the volume. Okay, the key is right here, the volume of blood. Okay, so I want you to be thinking about what factors decrease preload. Okay, what factors decrease preload? Take a moment, do your little chat box thing. So what types of disease processes? Okay, I already gave you one this morning. We're talking about Mr. Jar. What a great name. I should just patent my names. The other things that I want you to think about, factors, right? Factors can also be the drugs. So think to your pharmacology, okay? The things that you went over. What kinds of things, what kind of drug can decrease someone's preload? I do have to tell you guys, hemodynamics are hard. I get it. I understand. I know that your brains might already be on fire and we're not even an hour into class today. Okay, so again, I just want you to understand the concepts around it, okay? There's nurses I work with that sometimes don't really understand this, so don't feel bad if it's hard. Not to throw shade on them. It's a hard concept, okay? Okay, so factors that decrease preload. I love it, okay? Huge one, right? Dehydration. We live in Phoenix. It's 500 million degrees outside. People don't drink enough water. They end up on the sidewalk with all sorts of burns, and they come in and they're hyperthermic, right? Their temperature's 107. So dehydration, that hypovolemia is huge, okay? Again, really, hypovolemia is kind of the umbrella, right? It's kind of the umbrella, and then what happened, okay? They're dehydrated. We already talked about this, right? Where was it? I just thought hemorrhage, okay? Hemorrhage. Hemorrhagic shock is a huge one that can cause decrease in preload, right? So again, the cup, right? The cup that we're pouring into the heart is empty, okay? The cup is empty for whatever reason, okay? So the volume, there's no volume in here, okay? Let's see. Yes, I love it. Lasix, diuretics. Diuretics can decrease preload, right? Absolutely, okay? Let's see. I feel like vasodilators, yes. Nitroprusside is a great one. Do I see nitroglycerin? Yep, absolutely. Nitroglycerin specifically helps to decrease venous return, okay? Helps to decrease venous return. It's key when we're talking about someone that's either in heart failure or they're having some sort of acute coronary syndrome situation, like an MI, okay? So again, a decrease in preload. So this would mean that if we had a CVP at the start, okay, your preload is super, super high on this patient and it's causing issues, okay? What would I anticipate my CVP to be?
No.
Be careful. We are wanting to decrease preload because our preload is too high. So our CVP, if it's too high, what would it be?
9. Over 8.
Great, over 8, 9, 15, 20, 25, okay? Because we're wanting to do things that decrease our preload, like nitroprusside, nitroglycerin, okay? But then disease processes, they also can decrease our preload, like hypovolemia, okay? Okay, so this is the caveat. I kind of already gave you the answer, but it's fine. Factors that increase preload. Okay, I just gave you an example. Heart failure. So you can't use that one. Heart failure. can increase someone's preload, right? Think about the drugs that we have that we've learned about. What can increase someone's preload? That's increasing the venous return to the heart. Or, conversely, right? What can increase that volume? So this would be the opposite, right? So if I'm wanting to increase my preload, that means that my CVP is probably low, right? Below 2. Okay, that's that objective data that we have. Okay, so things that can increase it, I love it. It's basic, right? Fluids. Fluids can increase that. What kind of fluids? Well, it depends, right? It could be LR, could be NS, okay? I love that someone put blood products that absolutely can increase someone's preload, okay? Heart failure, yes, 100% can increase someone's preload, okay, from the disease process. And then also what can increase it is vasopressors. Epinephrine, vasopressin, okay, someone put pressors. Too much fluid, sure, absolutely, okay. Working out, yep, sure, absolutely, can increase it. What about, what about renal failure? Can that increase someone's preload? Why? Yeah, absolutely, right? Their kidneys aren't working, okay? So what comes with that kidney failure is the fact that, I mean, it's a slew of things, right? They're not peeing, they're not making that urine, so their electrolytes are all messed up, but they're also fluid overloaded, right? So oftentimes they need things like dialysis to accommodate and help with that increase in the preload, okay? Does that make sense? Do you guys understand the difference between someone that has a disease process that's increasing the preload and then things that we are giving to manipulate it to increase it? Does that make sense? Do you understand the difference? Yes? Okay. It's always hard if you look out and people have those looks where I'm like, are they overwhelmed? Is there like a headlight up here that they're looking at? Okay, so let's change the gears. Again, remember guys, these are all under the umbrella of stroke volume, okay? This is all helping us to maintain that cardiac output, okay? So the other component of afterload, right, is described as the resistance to ventricular emptying during systole. They need to have the opening of the pulmonic and aortic valves to push the blood through, okay? So what factors can increase afterload? So when you look at afterload, when you think about it, why I capitalized it too, is I want you to be thinking about the resistance, okay? The resistance that the heart has to overcome to pump blood forward, okay? Now there's definitely different components of vascular resistance, okay? So it could be the length of the vessel, okay? What we talked about with my lovely picture over there, it could be the diameter or radius, how big the lumen, the vasculature lumen is, okay? And then it could also be the viscosity of blood, okay? So what do I mean when I say viscosity of blood? What do those words mean? Thick, right? So our guy, Mr. Jar today, do we think his blood is super thick or very thin? It's probably thick. Why? He's dehydrated, right? Absolutely. So his could be thick. When you travel to high altitudes, okay, every summer my family and I go camping in the Sierra Nevadas, and my family is probably so tired of me saying this, but I say it every year, is I say your blood is sludge. Drink that water, okay? Drink that water because your blood is sludge. We don't want us to have that effect, okay? So again, viscosity of blood, the diameter, okay, or radius of the vasculature, and then the length of the vessel, you can affect someone's resistance of what they have to overcome to pump the blood forward. I'm so sorry. You might consider moving. I'm so sorry. But you guys know this. I like to walk around. This is how I get my steps. Okay, I got to close my activity rings. Okay. So again, we are thinking about being able to manipulate those factors. Okay. The length of your vasculature, are you able to manipulate that? No. Okay. What you got is what you got. Okay. Genetics, what the good Lord gave you is what you got. Okay. But can you manipulate the viscosity of someone's blood? 1,000,000%. Okay. Whether it's by fluids, maybe it's by heparin of thinning the blood, right? Okay. So the drugs, we can manipulate someone's viscosity. Can you manipulate the diameter or radius of someone's vasculature? You better believe it, right? Absolutely. So again, factors that can increase the afterload. Okay. I love it here. Okay. So hypertension. Hypertension, just straight out the gate, we got hypertension, can increase someone's resistance. Okay, the diameter is very, very small. Okay, so they have underlying familial hypertension. They are going to have an increased afterload. Okay, right out the gate. Atherosclerosis, plaques. That's 100% going to increase resistance, right? Because the blood's got to go through all those plaques. Okay. What about diabetes? Can that increase someone's afterload? Right? We have all those sugar particles stuck on the vasculature. That could cause some increased resistance, right? Okay. Vasopressors. That's a drug that we manipulate to vasoconstrict, make the vessel a little bit smaller. How I think about vasopressors is I think about a floppy spaghetti noodle. Okay, floppy spaghetti noodle. You can't really do anything with it, right? So I think of the vasopressors making it stronger, and clamping down is like a pipe cleaner, okay? So do you guys know what a pipe cleaner is, or am I like really aging myself with you doing art projects with pipe cleaners? So pipe cleaner is a little bit more, you can mold it, right? But it's stronger, okay? Spaghetti, it's floppy. You can't do anything with that, right? So a vasopressor is going to clamp down. It's going to make it so it's increasing our afterload in a good way, okay? In a good way, when you have spaghetti noodles, okay? I love it. Atherosclerosis, we talked about that. Perfect, excellent, good, good, good. Okay, questions about this? Okay, see the connection, why we're taking the time to go over this? Now, factors to decrease afterload, okay? Think about the drugs that we talked about. Think about the ones that you read about. What can decrease afterload? What can decrease that resistance, right, that the heart has to overcome?
Vasodilators?
Yeah, I love it. Put some out there. Which ones do you want to do?
Nitro.
Yeah, nitro. That's a good one. Nitroprusside, nitroglycerin. Okay, so we have a lot of vasodilators, right, on here. We have nitroprusside, we have nitroglycerin, plus the word vasodilators, right? So again, vaso, right, is a vasculature dilator, right? The word right there makes it bigger, okay? So what about a disease process? Sickle cell, I'm not sure actually about that. I'll have to look that up and see if it increases afterload. Does anybody want to talk about it that put it? You want to be brave and talk about it and how it does sickle cell? No, it's okay.
I figured if it wasn't me
Okay, I love that you said that, but I love that you're gonna explain to me. Perfect, do it.
But like, no, so sickle cell, what was the previous one?
Previous.
To decrease afterload? The
Yes.
thickening of the blood
Okay.
causes the other one, right? The one
Okay, so you're
previous.
talking about like how like that affects the vasculature, like
Yeah.
viscosity of blood.
Yeah, so.
Okay, so you're thinking sickle cell, then break
If,
like.
I'm just joking, like if somebody didn't have sickle cell,
Uh-huh.
like, it would decrease the afterload. So,
Sure, I'll take it. So essentially, you're focusing on the components of the blood,
yeah.
right? I love it. That sounds great. That's perfect. Good critical thinking. I love it. Perfect. So yeah, I think that could totally make sense. I'll totally contribute to that. What about another disease process? One that I always talk about because we live in Phoenix and it's really hot here. Hyperthermia. Hyperthermia can decrease someone's afterload. Okay? Make them
Because when it's hot,
super
you
floppy.
vasodilate, right?
Correct. Exactly. Yes, exactly. Excellent. So hyperthermia. And then also be thinking about just antihypertensives, right? That can decrease someone's afterload, okay? That can increase the diameter of the vasculature, okay? So ACE inhibitors, calcium channel blockers, beta blockers, all those antihypertensives can all result in a decrease in afterload, okay? Questions about this? No? Okay. So here is the definition, okay? So again, within afterload, how we measure it, right? How we measure it, please don't be freaked out. Do not memorize these. I just need you to be aware of these terms, okay? So we measure afterload by the PVR, the pulmonary vascular resistance. Because remember, guys, what I talked about is the resistance for the heart to pump blood through, right? Right side and left side. Right side, you're pumping it through the pulmonary vasculature, right? Everybody tracking with your anatomy? Do you remember that? And then systemic vascular resistance, SVR, is the rest of the body, okay? Is the rest of the body. So these are the normals, okay? And then I know you guys want this. I want it. It would be so much easier. But unfortunately, afterload and blood pressure are not the same thing, okay? So blood pressure, the actual formula is cardiac output times systemic vascular resistance. That's how you get blood pressure. Okay, I know, I wish it was afterload equals blood pressure, but it doesn't. Okay, so changes in the blood pressure are either due to the change in the cardiac output or the systemic vascular resistance. Okay, so how I need you to think about this, right? Make it make sense. In order to have a good blood pressure, okay, blood pressure, we care about MAP. You have to have a good cardiac output, okay? That's going to influence it. When you have a low MAP, you are going to have a low cardiac output, okay? Does that make sense? Okay. I know, I wish it was 1 equals 1, but that's not how it is. Blood pressure and afterload are not the same thing. Okay. Last component of stroke volume. Let's talk about contractility. So contractility is the strength of the myocardial contraction. Okay, so this is the last component. Okay, so preload, we have our volume. Okay, afterload, we have that resistance that the heart is over pushing for the blood forward. Now we need to talk about the contractility, how we can force that heart to contract to push the blood forward. Okay, so what factors affect contractility? Okay, so let's see, what do we have here? Contractility. Okay, I love it. We got some good things here. Okay, so contractility, a disease process that can affect it, 100% heart failure. Also age, okay? Someone that's 85 is probably not gonna have the contractility of a 20-year-old, right? I love it. Heart failure, age, okay? And then, let's see, tachycardia can sometimes affect it. Electrolyte imbalances, I love that, okay? We're talking about the heart, right? The heart is responsible for the contraction. That's where it happens, right? And so what electrolytes are key for that to be able to work? Potassium, absolutely. What else? Calcium, I love it. What else? Magnesium, excellent, good job. Okay, so all three of those, sometimes phosphorus too, but that more acts on the lungs, to be honest. But again, make it make sense, right? Make it make sense. So if you have someone that has low potassium, right? If you have low potassium, let's say your potassium is 1.5. Someone gave too much Lasix and they forgot to check the lab. Whoops, okay? So your potassium is 1.5. What could that result in? What?
Asystole.
Okay, absolutely. It could result in asystole, sure. Maybe before the asystole. What kind of arrhythmia could that cause? VFib, yes. So think about it, right? Right there, okay, I'm so sorry. I probably shouldn't keep passing that because you're gonna be like, who's that walking? So low potassium, right, causes that VFib, right? Ventricular fibrillation, where your heart is going like this, okay? So do you think if it's going like this, it's going to be able to contract excellently? No, it's not contracting at all, right? It's not contracting at all. So we can imagine VFib, there's zero cardiac output happening, right? They're dead, basically, okay? So make it make sense. We need that. We need those electrolytes in order to have the heart contract effectively. Here's the other component that I love, right? Oxygen. This is huge, right? If someone is having an MI and the heart is ischemic, do you think they're able to contract effectively? No, okay? So we need perfusion, we need oxygen. Myocardial ischemia can 100% affect someone's contractility, okay? Now let's talk about the drugs that you guys did, okay? So the drugs, inotropes. I love when people say this. They're like, yeah, an inotrope. Okay, what the heck does an inotrope mean? First of all, let's talk about an inotrope. Okay, a positive inotrope. So what does an inotrope mean? Don't just throw that word out, okay? I know you guys are excited about knowing what that is. Well, maybe you know what it is, but make it make sense, right? So what is an inotrope? It increases the force of the contraction. Excellent, good job. So it can increase our cardiac output. So maybe your cardiac output was 3, and I added a positive inotrope, and now my cardiac output's 5, right? What drug does that? What's an example of a drug that does that? Dobutamine, yes, it's a positive inotrope. There's a million others, but that's the one that we're gonna focus on for our class, dobutamine, okay? It's a positive inotrope. Okay, now conversely, what would be a negative inotrope? Yes, excellent, good job, yeah. A beta blocker is a negative inotrope, 100%. Why is it a negative inotrope? Because it slows down the heart rate. It slows down the heart rate, it decreases that contraction, okay? So it's considered a negative inotrope, good job. Okay, so again, lots of things affect contractility. One of the key components, well, I mean, they're all key, of stroke volume. Okay, again, why do we care about this? Well, because we want cardiac output. Okay, it's the third component of that. We talked about that. Okay, great. Questions about this? Yes.
Are you going to be specific about what increases it and what decreases it, or just in general what affects it? Because we didn't differentiate like we did the others.
Oh, sure. You're talking about like what decreases it and what increases. Oh, okay. Well, most of the time, what we focused on mostly was increasing it, right? Or making sure that it's effective. The only thing that I want you to know that can decrease it is beta blockers. And I think that it will make sense, right? Like the disease processes that we are going to continue talking about, right? When we get to cardiac, for example, you will be able to see that that can affect the cardiac output.
Yeah.
Does that make sense?
Yeah.
So again, I feel like that's kind of a
critical thing.
totally, yeah, exactly. To know that it can affect contractility and then in turn affect your cardiac output. So I think rest assured, my answer is that we're going to continue talking about it. Does that make sense? Okay. All right. Any other questions? No? Okay. I just want to finish this and we'll take a break. Okay. So we touched on this a little bit, but why do we care about MAP? Why do I care about the mean arterial pressure? Okay. So what is an adequate MAP? What are we shooting for? 65 and above. Okay. And so we want that end organ perfusion. Okay. We want that end organ perfusion. And so that when we talk about that, that means that my skin, my kidneys, right, my liver, my GI tract, everything is getting perfused, okay? Now, if I have a low MAP, let's say that my MAP is 40. How will my patient present with a MAP of 40? So it's a 25-point difference, right? 25-point difference. What do you think? How are they going to present? Okay, cold limbs. Okay, what else? Okay, so their cap refill is going to suck. It's going to be greater than 3. Absolutely. What else? Urine output's going to be low. Okay, excellent. What else?
The level of consciousness.
Yes, absolutely. So a MAP of 40 is pretty low, right? A MAP of 40 should be concerning to you. Okay, so a MAP of 40, yeah, they're probably going to have a level of conscious change where they're going to be lethargic, and they're probably going to be confused, right? What do you think their cardiac output's going to be if their MAP is 40? It's going to be low, right? Because if you think back, right, make it make sense. Your BP equals cardiac output times systemic vascular resistance, okay? So we need a cardiac output to have a MAP, right? Okay, so again, the MAP matters. We need that, okay? How can I increase someone's MAP? Okay, fluids, perfect. What else? What other drugs can I use to increase someone's MAP? Vasopressors, right? We'll talk about those today. Okay, I like it. Rapid breathing, 100%. Okay, what do you think what are my liver labs gonna show? If I have a low MAP of 40, they're gonna be high, right? What do you think about the liver in general? The liver is gonna be shocked because it's not getting perfusion, right? The liver is in charge of lots of different jobs, right? So if I have a MAP of 40 for a long time, not only are my liver enzymes gonna be high, but what other things are gonna happen, do you think? Think about the job of the liver. Okay, so maybe low albumin, okay. Okay, perfect. So the ability to metabolize the drugs that we're giving is going to be very low, or the drugs that they're taking illicitly. Sure, absolutely. What else?
Increased ammonia levels.
What'd you say?
Increased ammonia levels.
Okay, excellent. So increase ammonia levels, 100%. So they're going to be confused, right? Because their ammonia is going to be high. I heard someone said sugar. Okay, liver's in charge of glucogenesis. So their sugar is probably going to be low. Hypoglycemia is probably going to be one of the results. What about coags? Is the liver in charge of that? What about platelets? The liver in charge of that? Right? Liver makes thrombin. We need thrombin to make thrombocytes, which are platelets, right? So we could think that the platelets are going to be low. Think that our coags are going to be high, which increase, right, our chance of bleeding, right? We can't clot. Does that make sense? Okay. So again, lots of things, lots of bad things are going to happen when our MAP is not adequate, okay? Do you think that our gut is going to be able to be perfused? Okay, do you think that peristalsis is going to be stellar if your gut is not being perfused? No. Do we want an ischemic gut? Absolutely not, right? Because that can lead to dead gut, which people die from that, okay? So again, map matters. We need to make sure that our patients have adequate maps, okay? Questions about this? This is huge, guys. You will see this in every single lecture we talk about, every single one. Okay, so let's do some application. My favorite time, okay? So this is very similar to Mr. Jar, okay? Mr. Jar was admitted with a GI bleed, okay? You got a report on him this morning. So what are we talking about? How will his hemodynamics, you kind of already, I mean, I gave you lots of hints, but let's see if I remember, okay? How will his hemodynamics be affected? Let's talk about preload. What is his preload? What is his afterload? Stroke volume, right? Heart rate, cardiac output, what do you think? And then how can we improve his hemodynamics? So take some time. You absolutely can discuss this with your teammates at your tables. I love it. Nursing's a team sport, okay? But take a couple minutes and write down your answers so we can talk about it. Because remember, all these concepts can be so abstract, but again, why does it matter? Why are we taking the time to talk about it? Well, it's important to make sure that we can apply it to the patients that we see, right? Make it make sense. Do you have a question? Okay.
So if I don't have contractility, nothing is necessarily affecting afterload.
Yeah.
Okay.
But your preload is low.
Okay.
Does that then make your afterload?
It's gonna try to compensate.
It could. 100%. Yeah. For sure, absolutely. So your body is miraculous in its compensatory mechanisms, but they do run out. So initially his afterload could be higher because it's trying to compensate, right? It's trying to help with the components of the stroke volume that it's lacking. Does that make sense? But it won't last for very long. Oftentimes I say that happened before they came to the hospital. You won't see that with us. Okay, does that make sense? Okay.
All I remember from last semester is you were born.
You guys ready to discuss this? Yes, maybe so.
But we would need a low key.
All right, let's talk about it. Okay, so GI bleed, right? How are his hemodynamics going to be affected? Well, they definitely are going to be affected, right? So let's start in order, okay? So preload. What is our preload going to be? It's going to be low, right? Because our volume, what's returning to the heart, is going to be low, okay? Because he's bleeding from his GI tract in whatever capacity, lower, upper, whatever. Okay, so our preload is going to be low. So if I had a CVP hooked up with the distal port in my central line, hint, hint, see how we insert some review in here, then what can I anticipate that number to be? 1 or 0, right? It's going to be low, okay? So preload is going to be low. I love it. What about afterload? Okay, so Alicia and I talked, she asked about this, right? So we'll get into this more when we talk about shock, but initially when you have hypovolemic shock, and this usually happens when Mr. Jar was at home, probably drinking his vodka when he started to have the GI bleed, is that our bodies are really miraculous in the compensatory mechanisms that they secrete, okay? Because they don't like things to be out of homeostasis. They don't like alterations in this, okay? So initially, probably when he was at home finishing his drink, his afterload may be increased, okay, to help compensate for the other losses. But when they get to us, it's probably gonna be low, okay? It's probably gonna be low. And you can think about, right, the factors that we talked about. So the viscosity of the blood is gonna be a problem, right, mostly with the afterload. So the resistance could, well, I mean, I feel like you could probably make an argument for high or low, but most of the time the afterload is gonna be low, okay? Now, stroke volume, right? So we didn't talk about contractility. Did I? No, I don't have that up there. But with the contractility, let's say that really quick, because again, we're talking about the three components of this, right? So what do we think about the contractility?
It would be high, because it's compensating.
It could be. It could be, or it could be hindered because we could think about what drives contractility. Electrolytes, oxygen. Do you think his electrolytes and his oxygenation is going to be amazing? Absolutely not. So contractility, yes, initially with that compensatory mechanism, it could be higher to help like make things better, but one can venture to guess that it's going to be affected. So the pump is having a hard time pumping, okay? So again, the main thing, right, is the volume. In stroke volume, we're missing the volume, right? We're missing the volume because we have a GI bleed, okay? So if we talk about all of the stroke volume components, preload, afterload, contractility, what do we think our best friend's gonna be doing here? It's gonna be high, right? It's gonna be high because it's gonna be saying, whoa, let me help you. Let me help you because I see you have a problem. You've lost a lot of volume. Let me help you, so I'm gonna be high. Why? Because I'm trying to maintain a cardiac output. But I could probably venture to guess that my cardiac output is going to be what? Be low, okay? And then in turn, how is that going to affect my blood pressure and my MAP?
It'll be low.
It'll be low, absolutely, okay? So, what do we do to fix it?
Fluids.
Okay, what kind of fluids?
Albumin.
Okay,
I
okay.
heard somebody just say that, that's why I said it. I don't
Did
know.
you said albumin, right? Okay, I love it. I mean, that's great. Okay, so
She's self-aware.
I think that in the meantime, sure, but
Stop that bleed.
you have to stop the bleed, right? You have to stop the bleed. That's the problem, right? And then what volume, what type of fluids, I'll rephrase it, what type of fluids did I lose? Did the patient lose?
Blood.
Blood, right? So do I want to just give isotonic fluids and albumin to someone who lost blood? No, right? What should I do?
Replace blood.
Replace blood. Okay, so I want some blood products. What type of blood products?
Type of blood cells.
What?
With PRBC.
Okay, so packed red blood cell. Okay, I love it. Okay, so let's say that our hemoglobin's 4. Okay, so 1 packed red blood cell, 350 cc's of that, is that probably going to be sufficient? No, let's give some more. So let's say that we give 3 packed red blood cells. Boy, I just spit, so sorry, but this was a good distance, okay? You did not feel it, okay? So 3 packed red blood cells. What is that going to do to the rest of the blood in my body? What is it going to do to my coax? What is it going to do to my platelets, for example?
Yeah, some moisture.
It could dilute them a little bit, right? Because I'm adding more volume. This guy, Mr. Jar, we don't know, but he could have a liver disease process where his platelets are already low, okay? Where his coags are already affected. So anytime you have someone that has a GI bleed, you are probably not only going to give just packed red blood cells, okay? You probably are gonna give some fresh frozen plasma, which is gonna help that clotting, okay? You probably are gonna give some platelets, okay? And then you're probably gonna give some cryoprecipitate, which can also help your fibrinogen, which helps your clotting. Yes, ma'am.
Is it all separated out like that? Or
Yep,
is it ever
it's all
just, like-
separated out. So the packed red blood cells are in like a red bag.
Yeah.
The FFP is in a yellow bag that looks just like the red one, okay? The platelets are in like a little bit more flimsy bag that is yellow. And then the cryo is in the smallest bag, and it's yellow too, yeah.
I don't know, but when I was I had a man that did this, and then it was like, I guess it was the cryo, because it looked like a kind of like a grenade bag.
Yeah, totally, 100%, yeah.
Just squeeze it, so I was standing there squeezing like,
I'm not sure about squeezing it, that's interesting. Did it work when you squeezed it?
I guess they didn't have enough pumps, so, I don't know
Like
what.
Alaris pumps?
I guess, so they was like,
Wow.
just
What was
standing
the
there.
pressure tubing you have to?
There is the hand pump tubing that we do, but like this motion and this motion are different, so it sounds like you were squeezing the bag.
Stand there and go like this. Go
I
like
mean,
this.
sure, you were acting as like a pressure system, 100%. So strong work was hopefully helping get into the patient quicker, okay? But again, if I think about it, I'll take pictures of the blood products, but just know that it's separate, okay? Has anybody donated blood?
Yes.
I have, but they always take the full thing.
The
I
full
didn't
thing,
realize
right.
they will then separate it all.
Yes, so you can, which is interesting. The reason why I was looking into this, because I have to do it for my clinical letter, blah, 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 it's all the whole thing. So when you give whole blood, it's very quick, it's like 10 minutes, okay? But then if you give plasma or platelets specifically, they have to filter it out, so it takes a lot longer. It's like a time investment, okay? So again, it depends, but yes, please know that there's different blood products that are doing different things. So it's going to affect different labs, okay?
I guess I knew that they like take different things and sometimes only take parts of it, but I guess when you're donating the full thing, I didn't realize
Totally.
they then go.
They go and like separate it,
Separate it.
absolutely, yes. And then you'll notice on all the blood, usually, I say that, I shouldn't say all the blood, but I would say like 99% of them, when you are checking it, when you're looking at the blood product, and I hope you have the opportunity at clinical to look at them, but it will always say leukocyte reduced. And what that means is that you just gave your blood, which it contains leukocytes, right? You are giving your white blood cells, but they take that out because they don't want to give that to the next person, okay? Does that make sense?
Yeah.
Okay, so again, here we have someone where our hemodynamics are done. Yes, we need to stop the bleed. They probably need an endoscopy, right? But we also need to give volume. We need to give those blood products, okay? Well, sadly, blood bank is backed up. They just called, it's gonna be an hour. Oh my God, what is happening, right? This guy, his blood pressure's in the 40s now, right? Everything is going to crap. I'm giving my liter bolus. I hung my albumin, but oh man, okay, now the map is still 50. Should we just let it ride? Hope for the best? Sorry, Mr. Jar. Hang in there. What else can we do to help our hemodynamics? What'd you say? Yeah. Okay, so we need to constrict more. Yes. We need to increase our map, right? So what drugs should we hang? Okay, so dobutamine is going to help our contraction. Okay, it's going to help our contraction. However, talk a little bit more about this. It does have that decrease of afterload, so it can decrease someone's blood pressure ever so slightly. And in the essence of dehydration, it really decreases your blood pressure. So in this case, be careful of starting dobutamine, okay? You could start it, you just have to anticipate that you're probably gonna have a further drop of your blood pressure, okay? So what other drugs could I start to help my hemodynamics? You said it, you said constricting. What types of drugs are gonna help constrict? Vasopressors, okay? Give me one. Okay, epinephrine. I heard epinephrine. What's another one? Vasopressin, okay? Antidiuretic hormone. What else? What's another one? Norepinephrine, okay? Excellent. Okay, so again, remember, blood bank is taking 500 years. Did anybody work in lab before I throw some shade? Okay, so I love lab, I love blood bank, don't get me wrong, but sometimes I'm like, please, my patient is dying, I need this stuff right now, okay? And it takes a while. But in the meantime, you cannot let your patient just chill with a MAP of 50. Why? Because that's affecting my cardiac output. It's affecting my end organ perfusion. So in the meantime, I'm starting my vasopressors. I'm probably starting norepinephrine first, okay? It's usually the first line vasopressin, okay? So again, I can't just let him chill with a MAP of 50. I know that he needs volume. I know he needs blood products. But in the meantime, I'm gonna start the vasopressor because I can't just leave him with a MAP of 40 or 50. Does that make sense? Okay, one more and then we'll take a break. Does this make sense, the application? Is all the pieces falling in? Okay, good. Okay, so this is kind of changing changing the keys a little bit here, okay? So a different perspective is a CHF patient, okay? Congestive heart failure patient. Okay, they come in, they decided not to take any of their medications because they wanted to enjoy Labor Day weekend. Who doesn't, right? They wanted to go to the barbecue and be outside when it's really hot and go swimming and not care about their drugs, okay? So they're being admitted for a CHF exacerbation, okay? Now, how is their medical management centered on their hemodynamics, okay? Be thinking about each of the components, okay? Preload, afterload, contractility, and then their heart rate. They didn't take any of their medications, okay? So be thinking about what are they gonna look like, and then what are we gonna do about it? Okay, so again, nursing's a team sport. Talk amongst your table mates to help figure this out, okay? And remember what the core of the problem is, you guys. The core of that problem is the heart, the pump. Did everyone sign in while you guys are discussing this? If you didn't, it's up here on the table, the extra table.
My head hurts.
Make sure you're typing up your answers so we can talk about it. Some people are visual learners, so it's good to be able to see it up on the board.
No, it's what I'm saying, because it's heart failure. The heart is failing, so it's not, so we need to go.
Continuous pulmonary pressure, so it's forcing the fluid.
And except for low to high pitch scenario.
2 more minutes, guys, and we'll discuss it.
So they have a lot of fluid in their heart. No. Yeah, heart rate's gonna be low, yeah. And she said that heart rate is really high, so that's low. It's the same. I'll say that after the high. So high, low, and she's gonna start working harder to try to get that.
Like hypertonic has less.
Even though it's I don't know. Something like that. I think we're having this practice.
We give it at a really slow.
Someone would be treated right away. Depending on the electrolytes, replacements, or if it's, would you think that electrolytes would be high? Because of this?
Yeah, that's literally what, yeah, I was like, oh. Yeah.
Okay, you guys want to talk about this? Okay. So let's start with how your patient is going to present. Okay? So CHF, right? First out of the gate is our heart, right? Our heart is not working, okay? Scarlett nailed it on the head. Heart failure, right? Your heart is not pumping effectively, okay? So let's start there. That's the core of what we're talking about, okay? So let's break it down into our stroke volume components, okay? So if the heart is not working appropriately, what do we think our preload is going to be? It's gonna be high. Our CVP is probably gonna be 25. CVP is gonna be 25, okay? It's going to be high. Why? Because the heart is not pumping effectively, so everything's backing up. Where is it backing up into? The lungs. So we're gonna have some serious pulmonary edema, crackles, things are not gonna be awesome. Because remember, he stopped taking all his meds. He wanted to enjoy that barbecue and go swimming and not have to worry about any of that. He didn't want to have to keep getting out of the pool and go pee, right? Or maybe pee in the pool. I don't know. Stroke, right? So what about my afterload? He's not taking any medication, okay? What is my afterload probably going to be? It's going to be high, okay? Because again, my vasculature is probably going to be super, super clamped down, okay? Because remember, afterload is the resistance that the heart has to overcome, okay? The heart that's failing can't really overcome any resistance, so the afterload is going to be high, okay? And then finally, what did you think our contractility is going to be? If the pump is failing, heart failure, right? The pump sucks. It's not able to pump effectively. Contractility is going to suck, okay? So again, all of these components of stroke volume are bad, okay? So if we look at stroke volume, our best friend is going to be like, ooh, stroke volume. Things are not good in your camp. Your preload is super, super high. Your afterload is high, okay, because they're not taking their antihypertensives, their ACE inhibitors, anything like that, because they just stopped, right? And then their contractility, they're definitely not taking that to help with that drug, because it stopped. They're like, I wanted to party this weekend, okay? So you can anticipate that if this is bad, what is my best friend gonna do? I got you, let me help you. So it's probably gonna be tachycardic, right? So heart rate is probably going to be high, okay? Because they're also not taking their beta blockers. Okay, well they might not be on beta blockers if they
Would that be
heart
like
failure.
fluttery then? Cause it's not very strong, it's just like.
Depends. It could be if they're in some sort of arrhythmia. Sure, they could be an AFib because they didn't take their amiodarone. Absolutely, it depends. But we can know that the heart rate's probably not going to be great. Okay, so if all of these components is bad, what do we think our cardiac output's going to be? It's going to be low, right? It's going to be low. Okay, the patient was like, I don't feel like taking my meds. So now I'm going to the hospital because I can't breathe, okay? I'm pale, I'm dizzy, I might be a little bit confused, okay? I might have a kidney injury that I gave myself because I wasn't taking care of myself, right? So what are we gonna do about it? What do you think we should do? So let's tackle each component, right? That's the easiest way to do it. So let's tackle the preload first, the first component of stroke volume. So what can I do to lower my CVP of 25, to decrease my preload? Diuretic. Cool. Let's give some Lasix. Love it. Okay, whether that's a drip, an IV push, whatever. That's going to decrease my preload. Okay. What about my afterload? How can I decrease my afterload? What do you think? Decrease my afterload. Maybe give an antihypertensive. Okay. Depends on what's happening in this situation, right? What their blood pressure is. But we may need to give an antihypertensive to decrease that afterload, to decrease the resistance, okay? What about contractility? How can I alter that? What drug could I start? Dobutamine, yes. Dobutamine, absolutely, okay? Because that's going to help my contractility. Am I gonna do anything with my heart rate? What do you think?
The rest are fixed now.
Excellent, yes. Okay, remember, sinus tachycardia, one of the many things, but one of the things I want you to leave my class remembering, okay, and we'll talk a lot about this next week. Why are they tachycardic? Why are they tachycardic? This particular patient is tachycardic because they didn't take any of their meds, okay, and they're trying to compensate for how stroke volume sucks. They're trying to maintain their cardiac output and they're doing a terrible job. Okay, so you're absolutely right. If we can fix the stroke volume issues, they probably will become less tachycardic. Absolutely. okay? So see how we can manipulate these hemodynamics, how a patient can present and we need to manipulate them to make things better. Does that make sense? Okay, good, excellent. All right, doesn't everybody love hemodynamics? Isn't it the most fun? I love hemodynamics. Okay, so if you guys have any questions, your excitement level should be at a 20, okay? Let's take a 10-minute break. So it's 10:33 according to my Apple Watch, so let's come back at 10:43, okay? Go to the bathroom, get something to eat, order your DoorDash, whatever you have to do, and we're gonna start the wonderful world of pharmacology.